Welcome back to Global Health with Greg Martin. We're talking about study design, and in particular, we're talking about the power of a study. We're talking about p-values. We're talking about effect size. We're talking about sample size. These are things that all fit together, and it can be confusing. And so we're going to try and muddle through it together, Kevin and myself. And let me just say, welcome, Kevin. Thanks for joining us today.
Thanks so much, Greg. Always happy to come on and talk about any medical topic of interest.
Glad to have you. Yeah. And by the way, Kevin is the chief executive of Nested Knowledge. People that follow my channel know that Nested Knowledge support the channel, and we're super duper appreciative of that. Kevin, we're just going to jump right in and start talking about the idea of the power of a study. Everybody's heard of the idea. If I read somewhere that there's an 80% power, what does that really mean? If you can give us the sort of layman's definition.
Yeah, I think that, every statistical concept is more complicated when you encounter it than you actually examine it. Power is simply, am I going to find the answer to my hypothesis? Will I actually detect it in my underlying study? So if I have a power set to 80%, that means that if there's actually an effect, so if my drug is actually better than the drug I'm comparing to, then I will find that in 80 out of 100 studies with 80% power.
Perfect. And I suppose it's quite interesting to hear you say that, because one of the features that impacts on the power of the study is the alpha value, or what we often call the p-value. And you can correct me if I get it wrong, because I get these things confused all the time, even though I talk about them and I use them all the time. But the p-value is the probability of the result that you're finding having been just a matter of chance. So you want a very small p-value. In other words, you want to say that if the p-value is very small, it's unlikely that this was we got this randomly. In other words, we can have confidence that the what we're seeing in the data is real, and
Yes.
we can have that confidence. And then the other term that I think we also just need to clear up, because it comes into thinking about the power of a study, is the effect size, and that's something that people often don't think about when they're thinking about a study. Can you maybe just talk a little bit about the effect size and why that matters?
Absolutely. So p-values, again, you're thinking about randomness. What are the chances that in this study, everything that we're finding, any difference we're finding, is attributable to chance? The joke that I like to make here is that if you are setting your p-value threshold to 0.05, you're basically accepting that 1 out of every 20 articles in the medical literature is spurious.
Yeah.
But I think that's more well understood, actually. The thing that it might be harder to, or just not as well discussed, is the effect size, where the greater the difference between the performance of one therapy and another, the fewer patients you actually need to sense that. And if we use a really hyperbolic example, like let's say we invent a magical therapy that takes the mortality from like glioblastoma from effectively 100% down to 0%. You will not need a lot of patients. The effect size there is extraordinarily large. The difference between the two therapies is major. That means that after a much smaller number of patients, you're going to sense the difference. On the first side of that, the more realistic examples, very famous one was the ischemia trials. They have a huge number of patients coming through and being tested for basically the use of drugs to lower blood pressure and similar. And the effects are so small. It's about different rates of different adverse events over time. It's about very small differences between these underlying studies and their outcomes. Between these underlying patients' outcomes. That's where you have to have thousands of patients to sense a given difference. If it's like a 1 or 2% or 5% increase in an outcome, that is where you're going to need to have far more patients in order to achieve the same study power. Based on a smaller effect size. So the larger the effect size, the fewer patients needed to achieve the power you're looking for.
And what's interesting about that, okay, so there's two things here. There's the effect size, but there's also sort of the clinical significance. In other words, there are some things for which a small difference, even a small difference, would be clinically significant. We would be interested, like if something, a small difference in, the amount of sodium in your blood can be the difference between life and death. But a small difference in, how much hair you have in your head, we literally don't care. So the clinical significance and the effect size are really things that require a bit of a judgment call. And this impacts on the sample size, because you want to choose a sample size that's appropriate for the effect size and the clinical significance that you're interested in. And maybe a way of thinking about it is like you could, because I'm interested in this idea of studies that are overpowered. In other words, it is possible to have a sample size that's so big that you pick up an effect that's so small that it's meaningless. In other words, yes, it's statistically significant. It meets that criteria of it's unlikely that you got this by chance, so the p-value is less than 0.05, fine, and you might even get that into a journal because they didn't read it carefully. But in actual fact, the difference between the two things that you were looking at really just doesn't matter. And it's a waste of everybody's time. And that would be an overpowered study. And so it's because of that that you would determine your sample size. You calculate your sample size by starting off and saying, this is the power that we want. And the power that you want will be a function of things like effect size and the p-value. And then it's also the variance. I don't know if you can talk to that for a second, because I know that that comes into the calculation as well.
Yeah, I think for this, we'll have to use a different thought experiment than mortality. So the effect size, you're going to need a larger sample size if you want to detect a smaller effect. So let's say that instead of mortality, we're talking about a scale that goes from like 0 to 10, maybe a pain scale that measures that patient's outcome. You shouldn't just assume that, 5 patients getting a score of 5 and then 5 patients getting a score of 0 is the same as, the same with 2s and 3s, right? The patient's range of scores that are coming in should really tell you different things. So whenever you have something like a score that you're using as an outcome, you always need to think about the variance across those, because it isn't really the same thing to have all your patients consistently right in the middle of a range versus having them distributed at the edges. That's not just clinically significant. It's also relevant for your statistics here. And there are many methods people use at my level. Like if you generalize this out across studies, right? You could say not just across patients, but across studies. You can have variance in the reporting of these different metrics. And if you don't measure that, if you don't statistically measure your heterogeneity across study populations, you're probably also going to be misinforming people about what you're actually finding. And there's a fair number of methods to do so. I think we should jump into those in a second. But to drill down on this question of variance and of how to measure these things, and your question of overpowered, I think that whenever these studies come out, people always also talk about subpopulations. You hear this in many cases where maybe we didn't get the effect in the main population, and this was the case actually in the ischemia trials that I just brought up, where it was more effective for patients that already had some pre-existing conditions. And so in that case, if you drill down on that slice of that population, they probably had distinct outcomes from the rest of the group. And that's where you're going to see that variance. And unless you drill down on that difference between patient populations that are being included, you're going to be you're going to be grossly oversimplifying your outcomes.
Okay. Interesting stuff. Thanks very much. Might some of this be easier to understand if we used a bit of a case study, like if you were to be designing a trial, for example?
Yeah. Please,
talk to us about your mindset. How would you go about that? What would you be thinking about? Give me the sort of lowdown on what's happening in Kevin's head.
Okay, so if we're going to jump into Kevin's head, I'm going to ask that we use the discipline that I'm the most comfortable with. Let's imagine that I'm designing stroke devices, because I've designed several stroke devices.
Right.
So stroke, clot your brain. The goal with a stroke device is to put a catheter into your femoral artery, snake up to your brain, pull the clot out. And this is a well-known practice. It's called mechanical thrombectomy, and I actually have sponsored a trial of mechanical thrombectomy. These mechanical thrombectomy devices are often compared to thrombolytic drugs, so clot-busting drugs. Those are injected into an IV, and then they go into your bloodstream. And the hope there is that the clot just dissolves from.
So you want to compare these two therapeutic modalities, right?
Let's compare them, and let's say that we want to not only measure does the clot get out. There's a score of how much of the clot came out. Let's also say we wanted to look at adverse events, and we also wanted to look at how the patient end up doing. For that, we actually have mortality, and then we also have a scale of neurological function. So those are the outcomes that we could look at. But at the very beginning of the study, I can say I'm interested in these stroke devices. I want to see if they're better than the thrombolytic drugs. But I have to say, compared with respect to what? And so with all those outcomes that I'm talking about, every new analysis that I'm throwing into there, I'm introducing more statistical complexity, because the more tests that I run, the more chance that I'm going to have some completely false positives just from chance, right? If I'm running one test that has a p-value of 0.05, then 1 in 20 chance of it being random. If I'm saying, let's test mortality, let's test hemorrhaging, let's test clot clearance, if I try to test all of those, I need to make sure that, number one, I'm only selecting the ones that are appropriate for powering my study, and number two, I can do a correction for that p-value problem, where the more analyses I'm doing, I should correct it so that the number of analyses doesn't lead to basically getting a false positive by chance.
Okay.
So I should pick my primary outcome, and that's a huge part of it. You should pick a primary outcome, and you should pick the effect size that you expect to come back from it. And I actually do this based on literature reviews. So when I was starting my trial, I actually looked at all other trials of thrombectomy devices, and I said, okay, what is the difference in neurological outcome, which was our primary outcome? What was the difference in neurological outcome between thrombolytic and thrombectomy treated patients? And we were seeing that it was in the range of like 15 to 20% improvement. And so you can use that, like if you're going to the literature for this, you can, not make it up. You can estimate this based on your knowledge, or you can estimate this based on data in the literature. And you can say, okay, we expect to see a 15% effect size. We expect rate of neurological outcome, positive outcome, to be 15% higher in my treatment group than in my control group.
Right. Okay, I'm beginning to see it coming together now. So you do a lit review, you get a good evidence-based sense of the effect size, and off the back of that, you sort of say, okay, if we were to power the study at 80%, given that effect size, given that we want to use a 0.05, this is what our sample size needs to be.
Exactly. You feed the expected effect size, and your power, you get to determine. You could say I want a power of 99%, but you're going to need a lot of patients to meet that. So it's a little bit about setting your standards, and then it's a little bit about understanding your therapies and what that performance should be. And I should highlight here, if you are designing a trial, be careful not to be optimistic on that effect size, because I've seen so many trials where they go out and they're very confident that this new drug, this new
miracle therapy, and then you get a negative outcome.
Yeah, and it's not because the therapy didn't work; it's because the over-optimistic estimated effect size led to a too small of a sample size, right? So if you overestimate the effect, then you're going to underpower your study. If you underestimate the effect, you may overpower it.
I think that there may have been, and I can't remember the details, but I remember in the early, during the COVID-19 pandemic, some of the vaccine trials, you had two competing vaccines, and one came out with a better result than the other, and it was actually a function of study design as opposed to the actual efficacy of the particular vaccines. And I remember that being a little bit of a controversial issue at the time. So this is really interesting.
It's something you have to consider, right? Like, you should not just read the newspaper article about any study. You should be looking at, depending on how deeply you want to prove out their claims, you should be looking at their methods. You should also be looking at things like inclusion criteria. That's another thing that I actually just review. I review all of my competitors' trials, see what patients they included, and I try to make sure I include the same patient population. Or if they've made a choice that I think is invalid for some reason, like they excluded a subpopulation that actually should be treated. And that's something that's being examined in stroke. Stroke's in the front half of your brain. It's really proven that thrombectomy is very effective, but only in the most recent RCT, the stroke's in the back of your brain. So previously, they'd excluded all posterior strokes from these studies. And you could return to it and you could say, hey, let's just keep going with that. We want to have consistency in how we're measuring these devices. Or we could turn around and say, actually, this is something that we've excluded a patient group that could benefit, and we should actually be analyzing them as well. So you can't even just look at the outcome. You can't just look at the sample size. You also have to look at who's actually being included in these studies in order to understand the effects.
Kevin, can we pivot from looking at one study to kind of, if we were to kind of apply these principles across multiple studies, and let's say we wanted to do a meta-analysis and look at the results from a range of studies in the same area?
Yeah, let's flip this in our heads. Instead of me designing a trial, let's say that I'm going and reviewing all of the trials on stroke. And I actually have done that. I can share that. You can see my screen, Greg?
Yep, see your screen.
Great. So we have a software where you can do a literature review. You search, you screen articles, you tag them with underlying content, and you can also do automated network meta-analysis. So that's what I'm going to do right now. I'm going to jump over to our page where we show our results. You can see here an abstract. This is actually from a published meta-analysis that I completed with some Stanford neurosurgeons. And we did pull down things like what were the patients that were included in this, and what were the major outcomes of interest. But I wanted to drill down on the meta-analysis side, because that's where we're not determining the power of studies in advance. We're coming in after the fact and saying, did they prove what they wanted to? And so we have the thrombolytic drugs, we have thrombectomy, and we actually examined also a combination of them. So there are many studies of a combination of those two. And in here, I can just see a summary of what were their outcomes across. So again, some of the patient characteristics that we care about was the stroke in the front half of the brain or the back half, for instance. But we can also drill down on things like neurological outcome. This is a simple score of neurological outcome, basically MRS 0 to 2. If you're below 2, it's considered to be a good neurological outcome. If you're above 3, it's considered bad. And if it gets up to 6, that's actually mortality. I can see that across every therapy. I can see that also all the way down to the study level. So I could look at any of the RCTs that were included and see what rates they had. But that only tells me their raw data, right? That tells me or really tells me their combined patient data set, but it doesn't tell me any inferences about this. I can make inferences about this myself, but I should probably do so with the help of statistics. And that's where the best practice is network meta-analysis. That's where you build out the comparisons of interest. So let's make a diagram and say, let's look at all the studies comparing thrombectomy to thrombolysis to the combination of the two.
Could you just define that for me a little bit more? Network meta-analysis. I know what meta-analysis is. Network meta-analysis is a new idea for myself.
So meta-analysis is combining studies and comparing them statistically. Network meta-analysis is a specific statistical method where you need studies to compare therapy A to B and therapy B to C and C to D. But if you have those comparisons, but I don't necessarily have comparison between A and D, I can infer it from the fact that A is better than B, B is better than C, and so on. And the network part of it actually is this diagram. So I can make a network diagram of all of the studies comparing these different therapies. And in nested knowledge, this is interactive, where I can say, show me a network that shows every different level of these therapies. Give me an odds ratio between every sub-therapy of thrombectomy against every strategy of treatment with the thrombolytic drugs. But let's keep this high level. Let's keep on the track of this neurological outcome. What is the patient's neurological outcome? With that, you do a network meta-analysis. So you compare A to B, B to C, and hopefully they all are compared directly. But if they aren't, you can infer by that connection through the network, and you create an odds ratio. An odds ratio is a very simple concept, and you actually have this as the outcome of your primary study too. So very often your RCT will also report an odds ratio for a given outcome. All that means is, what are the odds of this outcome with therapy A compared to therapy B? So we can ask ourselves, what are the odds of good neurological outcome with thrombectomy compared to thrombolysis? It's actually about 2 to 1. And I can click in on this to get a forest plot. This forest plot,
love it.
And I think this really can get across the findings of these underlying studies in a very simple visual, where we give the odds. So say the Jovin study has 2 to 1 odd, or a little bit under 2 to 1 odds. And then we also get a confidence interval. This, like it's like a p-value in the sense that it's trying to give you a sense of whether this is going to be attributable to randomness. But what it's actually specifically saying is not in the comparison, what is the chance of randomness, but what is the range of confidence that odds ratio is actually within. So we have a 95% confidence that the odds ratio for Jovin is between about 1.1 and about 2.7.
Gotcha.
So you then combine that and you get a cumulative estimate with a much smaller confidence interval. The more patients, the more data you have, the smaller your confidence intervals tend to get, because you're more confident. So this study, the Mako study, was very small. The patient population was not as large as for the other studies. And then if you combine all of them, of course, that's the largest population that you can get. And you want to have confidence that this modified Rankin scale neurological outcome, in fact, does give these patients that improvement that they're looking for.
Okay, I love it. I love it. I must tell you, whenever I see nested knowledge, and particularly when I watch you working with it, because obviously, like, you're a power user, being the chief exec of the company, and you show us how it's best use case. Like, this is what it's meant to look like. It's absolutely gorgeous. Absolutely love it. We're going to have to kind of end because we're out of time, but I just wanted to say thanks very much, Kevin, for joining us. People, if you haven't used nested knowledge before, you have to check it out. You've seen a little demo there of what it can do. It's absolutely amazing. A big thanks to Nested Knowledge for supporting the channel. Really appreciate it. Kevin, from me, have a great day. So that people know, there is a a cheat sheet that we have that'll give you kind of the how-to with respect to doing a lit review or a meta-analysis. There'll be a card on the screen at the moment that you can click on. Click on that card, you get the cheat sheet for free. It's a PDF, you'll love it. Okay, Kevin, thanks for your
so
time.
much.
Appreciate it.
Have a great one, everybody.
Okay, bye.